Hi, good evening, good morning, good afternoon, everybody. I'm Mohamed Moti from the Sorbonne University and Saint Antoine Hospital in Paris, in France, and it is my great pleasure to welcome you all to our regular journal club by the International Academy for Clinical Hematology. It is 7 p.m. in Paris, 7 p.m. in Nice, 6 p.m. in London, noon in Houston. And we are very privileged today to have two top experts in the field of MDS and CMML, namely Professor Guillermo Garcia Manero from MD Anderson in Houston and Professor Thomas Clouzot from the University Hospital of Nice in the south of France. I'm not sure yet, but he may be able to join us depending on his clinic. We may have joining us during the Journal Club Professor Azacitidine from Yale University. We'd like to acknowledge this unrestricted educational grant and the scientific steering committee of the IACH selected for this journal club this paper recently published in the Lancet Hematology. And this is about the use of azacitidine plus venetoclax in patients with high-risk MDS or CMML, phase 1 results of a single center dose escalation, dose expansion, phase 1/2 study. And the first author is a brilliant fellow currently at MD Anderson, Dr. Alexander Bazinet. And we are also very honored and privileged having with us to discuss this paper the senior author, Professor Guillermo Garcia Manero, who is, of course, a top expert and a pioneer in this field. You can see the summary of the paper here. And to make a long story short, this is really a classical phase 1 dose escalation, dose expansion study. They enrolled, of course, adult patient with treatment naive, relapse, or refractory high-risk MDS, so quite heterogeneous, or even CMML, but also bone marrow blast of more than 5%. Interestingly, they didn't exclude, as far as I understood from the paper, any, I would say, ECOG high, altered general status, and the patient were treated with azacitidine, but also oral venetoclax. And as it is usually the case in a phase 1 trial, the primary outcome was about safety and tolerability, but also about defining the MTD, the famous maximum tolerated dose, in order to plan for the next studies, I would say. 23 patients were included, and you can see some of them were really heavily pre-treated. And the overall response rate was quite impressive, 87%, 20 out of 23 patients. And obviously, it proved that the combination of azacitidine and venetoclax is safe, and definitely that provides a rationale to test this combination in future trials. And you can see here the conclusion of the editors on the journal, clearly highlighting that this combination has the potential to establish a new standard of care in this patient population. But this is what we're going to discuss with our expert, because obviously there is now an ongoing phase 3 so-called Verona study. You can see the characteristics of the patient. Interestingly, the maximum age was around 71, 72, and we'll discuss this because obviously some patients can be older with MDS and CMML, but the patient, the trial and the distribution was quite, I think, fair, fairly representative of what one would expect in this population, including a lot of TP53 mutated patient, but also therapy-related MDS or CMML. You can see the response rate I mentioned, but we will discuss this. I'd like to emphasize the relatively low mortality at 4 and 8 week, despite we're talking about a high-risk population. So I'll stop here now, and I'd like to welcome our experts. And I'm glad Professor Zeidan managed to join us, but I announced earlier, Amer, that you will be late because you're busy in your clinic. So welcome. This is really an amazing journal club having 3 top experts in this field. And guys, please don't forget that you can also join the discussion by sending your questions, your comments using the chat box or the Q&A, and I'll do my best to share them with the experts. So as it is usually the case in the journal club, my first question usually goes to the non-co-authors. So I don't know who's gonna jump in, Thomas or Amer, just to set the stage. Before I ask Guillermo about the rationale for this study, what is currently the standard of care of high-risk MDS? Maybe, Thomas, you can take this, and then Amer, you can take what is the standard of risk for CMML? So, Thomas.
So good evening. So maybe the answer won't be the same for Amer and me. I don't know. Today, I think in Europe, so as you know, venetoclax is available for acute myeloid leukemia, but today in France, it's not approved for myelodysplastic syndrome. So the standard of care is still azacitidine alone. I would like to say maybe the standard of care is a clinical trial for this patient, because azacitidine alone, as we know, it's not enough for our patient. And of course, we would like to improve the outcome of this patient. So the combination with venetoclax is, of course, an option. There is other option in evaluation today in this setting. Officially azacitidine alone, and maybe some center use the combination of azacitidine plus venetoclax off-label in maybe some subgroup of patients. We could discuss, of course, maybe a patient eligible for allo stem cell transplantation.
So, Amer, if someone goes to Yale to you with high-risk MDS or CMML, outside clinical trial, what would be your first option?
Yeah, I would say my answer is similar to Thomas, with one exception, is that I actually regard decitabine and azacitidine as equivalent. While azacitidine has been the only drug in a randomized trial to improve overall survival, we and others have actually done a lot of retrospective adjusted analyses in setting of clinical trials that had cohorts of aza and decitabine treated patients or real life registries. And all of these show similar outcomes between decitabine and azacitidine. So in my view, those are equivalent. And now, of course, in the US, I don't think it's approved yet in Europe, but we have the oral version of decitabine sidazoridine. So in my view, any of these 3 drugs is a standard of care, and any of them could be used for those patients.
Excellent. Thank you very much. So it looks like there is a lot of enthusiasm already, Guillermo, for this combination, although we're talking only about the phase 1 trial. So can you just explain to our audience, Guillermo, what was your rationale behind doing this study? Why do we need to have a combination? Because I think our colleagues mentioned that azacitidine has a survival advantage, so that's great. We have a good drug.
Thank you, Dr. Moti, for opportunity, and I'm happy to be here with Dr. Clouseau and Zeidan. Yeah, so there's an advantage in terms of survival, but I think most of us will agree that it's really dismal or suboptimal. And this drug was approved around 14, 15 years ago, a little bit earlier in the United States. So we need to do a little bit better. I totally agree with Dr. Zeidan that in our experience, both hypomethylating agents, maybe the three of them actually are probably potentially similar, but we need to do better and we need to improve from single agent HMA. In addition, we know that the prognosis of these patients, once quote unquote, they fail this therapy, drugs fail patients, not the other way around, but that's how we talk about these things, is actually dismal. So this HMA failure situation is really a difficult problem. So we need to do better in both sides, and therefore some therapy upfront that improves response rates and hopefully survival will be very welcome by our patients and I think the community of treating physicians. Remember, historically, we're talking about CR rates of 17%, although we can argue about this. Survivals by the big 001 trial, maybe 24 months, but Dr. Zeidan has shown significantly lower than that. So yes, compared to whatever the standard of care in 2000, that was very exciting, but we really need to do better than this.
But is there, and I don't know who wants to jump in, a biological rationale for combining an anti?
Yes, so the reality is, and this is a very convoluted story, actually. There is this very famous river in the south of Spain that goes in and out of earth and then goes twisting around. Actually, people have this idea that the AML group kind of pioneered this doublet. This is actually not 100% correct. The experience with the BCL2 inhibition started in CLL, and there were studies launched in both MDS and AML. For a number of reasons, the MDS trial got delayed. We can discuss this later, probably in terms of how to manage these patients. The rationale is that there is synergism between the HMA and BCL2 inhibition preclinically in AML and MDS system settings. And in addition, because we were a little bit delayed, we clinically benefited from the Viale study that showed an improvement in survival in older unfit patients with AML with this doublet that I understand is the standard of care, at least in the United States, for patients with AML. So there is a strong scientific rationale in high-risk disease preclinically of the combination. There is the data in AML. So I think this is a logical next step. To be honest, going back to this river analogy, when we started thinking about this, actually probably around 10 years ago, the sponsor of these trials were not sure, because if you remember, Muhammad, French-English investigators, probably in low-risk MDS, but there was this concept that maybe BCL2 inhibition could be deleterious in MDS, maybe by inducing more apoptosis, things like that. That could be the case, maybe in low-risk MDS, but not in patients with more advanced disease. So I think there is plenty of rationale why one will explore this combination.
Excellent. Thank you very much. No, that's very convincing. And again, congratulations, by the way. I forgot to mention this in my introduction. Really, this is an amazing work. And as you said, there has been some delay because I know very well the story in CLL, but today we know very well the value of venetoclax across all hematology, because this is a sort of an agnostic, I would say, signaling pathway. Thomas, the primary endpoint was about safety. So what did you think about safety? Because obviously, if I ask Guillermo, his conclusion was that it was safe and well tolerated. Maybe I would appreciate your critical appraisal of the safety in this phase 1 trial.
Sorry. So about the safety, I think I totally agree with Guillermo. It's manageable. So we know using venetoclax, of course, we increase the hematological toxicity, but today, I think we learn a lot of about azacitidine plus venetoclax in acute myeloid leukemia. So today, maybe we are more able to manage this combination. it is a real change for us to manage a patient with AZA alone or with the combination of AZA plus venetoclax. But yeah, so we increase the hematological toxicity, but in parallel, we increase, of course, the overall response rate, and it's what we expect using these drugs. So I totally agree. I think it's manageable.
Excellent. So, Amer, so Thomas is enthusiastic. Guillermo concluded that it is great. But if I want to be the devil advocate, actually, initially, before reading the paper, when I saw the title, my expectation was to see like a median age of 80 plus in this trial. And actually, what I noticed, the median age was actually 68 or 67, depending on the cohort. And the upper limit was 72. So I must confess that in our hands, some of these patients are like, considered as young and fit patient, and we would they would go for an induction and then maybe bridge to an allo. What are your thoughts here? And then I'll ask, of course, Guillermo, how they were included and what were the criteria.
Yeah, that's actually an excellent question. I was actually preparing to answer your question about the safety if you're going to ask me, and I think it's a safe combination in the right hands. So the same way you are looking for fit patients for transplant, you should be looking for fit doctors who know how to handle these combinations, because I think, as Thomas said, this is definitely much more myelosuppressive. It took us some time to kind of teach doctors that with hypomethylating agents, these drugs are slow to act. Don't do a bone marrow after one cycle and then stop HMA because it can take 4 to 6 months. And now we are going a full circle around telling them you need to do a bone marrow biopsy at the end of cycle 1, because similar to AML and what I've seen a lot of actually off-label use here in the US of venetoclax, and sometimes patients are given venetoclax continuously for months and they are continuously cytopenic and getting transfusions and no bone marrow was done at any point. So I think you have to be careful about the drug interactions, about the dosing for 2 weeks, about making sure that the patient gets a bone marrow, and if they are hypoplastic, you delay the cycle, you interrupt the treatment. So it's not something that you'd give to the patient and forget. And also, you need a lot of blood transfusion support. Those patients will need to come on average 2 to 3 times a week to get blood and platelet transfusions. So I think after the initial phase, once and hopefully if the patient gets into a response, it becomes easier, but the first few, usually 1 to 2 months, are quite involved. In terms of the fitness, I think you are spot on that. I think the biggest question in my mind about venetoclax is going to be, is this a bridge to transplant or is this long-term therapy? And I suspect based on the MD Anderson cohort, and maybe Guillermo can comment on that, is that seems like in many of those patients, the intent was to go to transplant based on the age. But I think this is a very important question.
So let me indeed ask Guillermo about this efficacy story, and I'll go back to you guys. So the efficacy in terms of response, Guillermo, was quite amazing, 80% plus. So, but that was in terms of overall response. But at the end of the day, one would like maybe to extend the survival of these patients. Well, first practical question we have, for instance, from a colleague in Norway, Dr. Agriano, about the duration of treatment. For how long did you treat them in this trial?
I mean, the intention is to treat them for as long as possible. I think the median follow-up on that trial was around 13 to 14 months. So this is a phase 1 study. So we're not really presenting phase 2 or randomized phase 3 data. But the intention, unless you can go for transplant, and we can discuss this issue of bridge a little bit later or whenever you think appropriate, Muhammad, is just to continue therapy for as long as possible. So it's not a plan like a few months and then see what happens. It's true that you may need dose reductions of the HMA and or the venetoclax, but the goal will be to, give this therapy forever. Because again, I don't think that we know what the natural history of HMA plus ven hypomethylating failure is. We actually have some data from Dr. Maiti, Konopleva, etc. in AML is dismal. So I don't think this will be any different in MDS. And we published many years ago, I think, a study that has not been reproduced because nobody has really asked this question, where we evaluated outcomes on patients where we stopped therapy. This is long old paper that were in a very good response to single agent azacitidine, decitabine, and we saw that everybody failed eventually. So, you know, that's a very interesting biological question, is why you need to continue on therapy. We have some ideas about this, but you need to maintain on therapy for as long as possible.
So here we have another question from a colleague. Speaking about response, when can we declare non-efficacy? You know, when you say, well, it's not going to work, 1 cycle, 2 cycles, 3 cycles, and then you stop it. I think it's a fair question.
I mean, we can hear from Amer or Tomas. I don't know, actually, because traditionally with single agent HMA, this is a good question to investigate. It's like 4 to 6 cycles of therapy, right? This is how this is defined. This is how kind of the FDA takes this. This is how protocols are written now for second-line therapy in high-risk MDS. But I don't know if this is the truth with venetoclax-based therapy. I mean, you could wonder if after a couple of cycles, you don't see a response, whether it's time to like think about something else. The question is what? It's not that there are many options. I don't have a good answer for this. I think today you're going to take this a patient at a time. So let's say you start with 15% blast or 10% blast, and you know you see some progression after 2, 3, 4 cycles. I don't know that you're going to continue on that. But if you see a gradual decline, but it's not yet close to CR or some response, maybe you will push for a little bit longer. But I don't think we have good guidelines. That's actually an excellent question that we will have to define, because if the Verona trial that you were mentioning earlier is positive, and if this becomes one of the standards of care, we will have to again redo all this analysis in terms of expectations post-failure HMN, time to response, etc. The time to response is fast, 1 to 2 months, but we will have to redefine all this. So these are very important questions, actually.
Excellent. Thank you very much. So, Thomas, you are quite enthusiastic about the safety, and you thought that this is very safe, and you were pleased with the results. On the other hand, Amer mentioned, which I personally believe is sort like this regimen. We have the high-dose chemotherapy on one hand. We have the whatever gentle treatment with hypomethylating agent alone. And then you have a sort of an intermediate regimen with Aza and venetoclax. And we have a comment from Dr. Kaloyanidis about this combination, and based on the experience of AML, where taking into consideration the older age in MDS patient and of course the marrow functionality, the neutropenia, how do you feel the dosage adjustment should be made in this population based on what the finding of the trials? Because I think they did 5 days of hypomethylating agents. What are your thoughts, Thomas? And then we'll bring this again to Guillermo and the rest of the team.
Yeah, so I totally agree. It's not the same population of acute myeloid leukemia, and at the beginning of the development of the combination of azacitidine plus venetoclax, we observe a lot of toxicity in this setting. So it's why also there is a delay for the development of the combination in this setting. But today with the 14 days of venetoclax and not 28 days like with EML, it's why I said it's maybe more manageable. But we will see in practice, because we learn a lot of in treating a patient with acute myeloid leukemia. Yes, with acute myeloid leukemia, we need to decrease the dosage of venetoclax. We need to decrease the time of venetoclax, and maybe we will have to do that for the MDS, like it was recommended in the Verona clinical trial. So So yeah, so I think maybe we will treat the patient with full dose for 1 or 2 cycles until to obtain a response, and maybe after we will adjust the treatment like we do today in acute myeloid leukemia. But for sure, the first 2 cycles will be more toxic, and the 2 first cycles need maybe, like Amer says, more transfusion, maybe more antibiotics, more antifungal therapy, and the first 2 cycles need more management from the physician.
Okay, so on one hand, you're talking really, and I think Amer introduced the concept of fitness of the physician, you know, to deliver whatever combination. Guillermo highlighted the need that we need to clearly treat them because the biology maybe is more complicated than we think, and it would not be appropriate maybe to stop very quickly. But here, there is a practical question, for instance, we received from Dr. Sujai Renchwar, 70-year-old male, MDS high risk. Apparently, Guillermo, they are adopters of your regimen as a venetoclax, and they have completed 5 cycles, but unfortunately, the patient has prolonged cytopenia. So Amer, for this patient, would you continue treatment? What would be your approach if this guy comes to you, for you for a second opinion?
Yeah, I mean, my first question and my hope is that this patient did get a bone marrow biopsy at one point and the patient was in remission. So I think the first step, in my view, is similar to what you do in AML. Is the persistent cytopenia related to the disease itself or related to the therapy? So if the patient has less than 5% blast, and I guess this is where it can get tricky compared to classical AML, because in MDS for sure there is more dysfunctional hematopoiesis, and some patients might not recover like good counts no matter what you do. But in terms of what you would do, actually, this is an interesting observation, because in AML, what we traditionally do is we reduce the VIN. Now in MDS, and this is something that the company, based on the phase 1 study that's similar to what Guillermo did, the study has not yet been published, but they presented this analysis where they looked at reducing the VIN, at reducing AZA versus letting the physicians do what they want in terms of dose reduction. And they found both strategies were similar. So they ended up recommending to reduce the AZA in the Verona, the ongoing phase 3 trial, in terms of dose adjustment. And when you add into the mix the whole continuum of AML, MDS, and how it's difficult to separate, I think it gets like tricky. Which one do you reduce? So I think the short answer is I would reduce something. Which one, I don't know. My traditional approach is to reduce venetoclax a little bit. Maybe I would go from 14 days to 10 days or 7 days. But I generally try to keep a little bit of venetoclax on board. I don't like to stop venetoclax except when after I reduce VEN, then I would reduce AZA a little bit, and then I would try to keep a little bit of VEN on board. But I don't think we know the right answer to this, and I'm actually interested to see what Guillermo and Thomas would do in those situations.
So Guillermo, let's dig a little bit deeper and try to have a sort of a more granular analysis of the results. Is there any association with the molecular features of the disease? And especially people, of course, are very interested about TP53. We had a lot of questions. What's your I know we cannot conclude from the small number of patients.
So this is actually very interesting, Muhammad, because we know that P53 mutated disease in AML, for instance, is not like the best kind of target for BCL2 inhibition. Patients that do better in AML are IDH mutated, NPM1 mutated, etc. The reality, though, is that in MDS, we are enriched for this population. Actually, this constitutes almost 40% of our patients at MD Anderson. They claim that regular communities around 8 to 10%. I doubt it. I think it's probably a little bit higher than that. So this is a major problem. And is for sure probably not the best approach. But when I look at the data, not only from our study, but also from the study that Dr. Zeidan was mentioning, this phase 1 multicenter trial has been presented many, many times. Actually, the response rate with the combo is not bad. Maybe the durations are shorter. But you were talking about, what about as a bridge to transplant? I don't see what damage do we do by adding venetoclax to these patients. Maybe suboptimal, but give me something else that is better, please, today, that is not on a hypothetical randomized study. You know, we were excited, and Dr. Clouseau was the leader of the APR. We can discuss that, but right now, you know, even in a trial, there is not much that we can do for those patients. So I think this is not, actually we do it. And indeed in this paper, there were patients with that. That said, Verona excludes therapy-related disease that are enriched for P53. So that's gonna be an interesting thing as the study comes by. So that's the P53 story. I don't know if you want to follow with the conversation that you were having in terms of dosing, toxicities, and things like that, or what do you want to do, Mohammed?
We have a lot of questions, so
okay.
Unfortunately we cannot. Time is running. So here
I would like to emphasize something very quickly there, if you allow me, because I think Dr. Zeidan kind of alluded, but he was not very clear. What I see is patients with MDS treated in the United States with an AML schedule, meaning 28 days. This is unacceptable, and you see a lot of toxicity there. If you do that, you're gonna probably eventually injure your patients. We see this actually now almost weekly. People are, our colleagues in the community are adopting the AML schedule into, so hopefully if there is anything out of this paper of benefit to the community, will be maybe the dose. That is at least at most 14 days. This is important message for this community, Mohammed, because I see this now not sporadically, like people are using Viale dose schedule for MDS. You cannot do more than 14 days. And indeed, probably 7 days or something like that eventually will suffice. And I agree with Dr. Zeidan. I don't know what the rationale is to decrease the venetoclax before the azacitidine, but I don't do that. We first decrease the BCL2 inhibition, and then we gradually go with the others. I don't know what the rationale is to maintain full dose venetoclax, but he went through that a lot. But please, don't use AML schedule here. I mean, I think that's maybe the only positive stuff of this paper that people could learn.
No, I think this is really an important advice to the community. Thank you, Guillermo, and we still have a lot to learn. So let's continue with the responses, Thomas. And obviously, as Guillermo mentioned, we need to be humble about it. It's a good start, I would say, but we still have a lot to do. And for instance, in the TP53 population, which is now becoming really a matter of concern, we have a question about whether there is a rationale or an option to combine this, to add a sort of a triplet, for instance, magrolimab. Any thoughts on this? That's one question. And the other question, and I guess this is what you do in Nice, is about using this kind of combination as a bridging to transplant. If the patient are fit and without comorbidities, having a suitable donor, what do you think, Thomas?
So for the first question about the triplet, why not? But we need to evaluate, of course, in clinical trials. So today, the triplet azacitidine plus venetoclax plus magrolimab is in phase 1 in acute myeloid leukemia. So I think maybe we have to wait the results of the phase 1 and maybe to move in myelodysplastic syndrome based on this publication. Maybe to choose the good dosage of venetoclax. For me, the data about the magrolimab seems to be really promising. As you know, the Verona study was performed in the same time than the ENHANCE study. So the two phase 3 studies are closed today, and maybe we will have some results about the TP53 mutated patient in these two studies, and maybe we could choose one or another one in this specific setting. For the second question about the transplant, I think if you want to undergo allo stem cell transplantation, even if the patient is TP53 mutated, the overall response rate is good with the combination of the venetoclax or with the combination of the magrolimab. So to bridge to transplant, the two combinations seems to be really interesting. Maybe if tomorrow we have some data about minimal residual disease, and maybe if the minimal residual disease is better with one combination of the other one, maybe it will be easier to choose one or the other to bridge to transplant with a deeper response. But today, I think it's all things we have to explore.
Excellent. Lots of questions, very few answers, in my opinion. One question to you, Amer, because it looks like while we're talking about phase 1 trial, this combination is becoming more and more popular. And that's probably good news because apparently it works. So here we have a question about whether you would be willing to use this combination in those patients with low risk MDS, but transfusion dependent.
Yeah, I mean, I probably know I would not do it in that setting. I think it's not yet clear to me how venetoclax would work in this setting. I think you alluded to some concerns about those patients having, as part of their normal biology, increased apoptosis, and I think this is a theoretical concern, but I don't think this is something I'm kind of willing to consider at this point. For sure, HMA treatment after failure of other things in lower risk MDS is reasonable. Maybe can be explored in very controlled setting, but I would not do it in that setting. Actually, I wanted to comment also quickly on the response rate, if you allow me, because I think in the MDS field you have like two big groups. Some group that would completely disregard any maro CR and tells you, oh, maro CR, forget about it, is completely useless. And then you have another group that would count all responses, including maro CR. And I think the clinically meaningful response, in my opinion, is maro CR plus some hematologic improvement. You want to see some blood counts going up. So I think this is something that you want to always want to see in your patients. And I think that goes to your question about the triplets, because I think a lot of it depends on what is eventually the goal of the treatment. And I have, like, again, conflicting feelings about triplets, because in very few patients are able to stay on even doublets for a long term. So you are talking about highly selected patient population. So in my view, the way to do this in the future is going to be treating those patients in sophisticated tertiary centers where treatment get initiated, and maybe some dose de-escalation. But I cannot imagine triplets for your typical older MDS patients in the community setting at any time in the future.
By the way, Amer, would you use, because we have a couple of questions from colleagues about the use of this combination after transplant, so assuming the patient high-risk MDS proceeded to transplant. A couple of questions, Dr. Meyer, Dr. Cipro, sorry, I'm not able to pronounce the name. Would you be willing to use this after transplant for maintenance, for instance?
I would, and in all honesty, it's more of I don't know if the right word to say act of desperation, but I certainly, in high-risk patients, especially those with complex karyotype and high risk features. We know relapse post-transplant is almost always a death sentence. And we know that the first couple of years, if the patient does not relapse, usually there is a good chance that their transplant might succeed. So I find very little negative value of adding some kind of maintenance. Now, HMA maintenance by itself did not seem to work. So I do think, especially for someone who went into transplant on HMA-VEN, that considering some HMA-VEN in the maintenance setting. Now, ideally, again, you want to have randomized trials to kind of show this for sure. But I do think it's one of the biggest problems we have right now post-transplant is the very high incidence of relapse. And I'm sure you see that in your practice all the time.
Excellent. One last question, because we're reaching almost the end, to you, Guillermo. You are the senior author. And this is about what to do today. What are you doing today in case of failure of this combination? We had a few questions about this. Outside transplant, of course. And what are the next steps from after this phase 1 trial?
So I'll go very quickly. So let's start with the second question. It's easier. I think we are all waiting for the Verona trial results. It's going to take a couple of years. This is a survival trial, has 500 patients. It should give us an answer. And I think at the end of the day, everybody is correct here. This may not be for everybody, but we need to do better. Okay, we cannot just support single agent azacitidine because some of these issues that we discussed. We need to individualize therapy, and we need better doublets. To be honest, if someone invents some therapy that is not HMA based 6 months from now, that will be very welcome, because we could do something new. But I am excited about the Verona, also about ENHANCE. I actually will be very excited about doing triplets and start maybe, having survivals that are better. So that's my take on this. So Verona will be critical here. For the HMA failure, I'm going to go quickly. It's tough. There is not a lot of clinical trials. So what do we do right now? How do I approach those patients? The first thing, you look at cytogenetics. Some of these patients are still deployed at the time of HMA failure. They can respond to low-intensity therapy. At MD Anderson, we favor nucleoside analog, like low-dose cladribine, low-dose, we don't use clofarabine anymore, but something like this. So protocol that we have right now that you could do anywhere in the world is low-dose cladribine, low-dose cytarabine, low-dose venetoclax. Dr. Kadia has shown this data in AML, older. It's kind of well tolerated. This, we've published many different papers. It only works in diploid, but you could get a better survival than the 4-6 months. Then the other important issue, fundamental, please, you need to repeat the NGS panel at the time of relapse. Why? Some of these patients may be FLT3 mutated. I know people think this does not happen in MDS, but it does. It's around 15 to 20% of them. That's obvious. And then, very important, look for IDH1, IDH2 mutated disease. This may be 5 to 10, 15% of the patients, but they really respond. The French have beautiful data with their studies, and we just published beautiful paper with enacitinib with a median survival of 22 months in HMA failure with monotherapy. Now, unfortunately, this is 5 to 10%. With the others, this is tough. Dr. Zaidan has shown a nice study adding venetoclax with some improvement, maybe low-dose CPX or something, but I think you're looking for a clinical trial. So from practical, look for cytogenetics, deployed chemo. Please repeat the mutations. Don't assume that the mutations are the same at relapse than at baseline, because you will get these surprises. And occasionally, maybe a quarter of the patients, you can really help them and rescue them, and maybe take them to a transplant, or if they are not candidates, have survivals that are better than the 4 months that you expected.
Well, thank you very much, Guillermo, for all of this advice. And thank you, Thomas Amer, for the words of wisdom. I think this is really a fascinating, exciting topic. And I keep on repeating that when I did my medical school, MDS chapter was like half a page, because the teachers would say, only transfusion, guys, and nothing else. But now it's amazing, the number of trials, but also the advances. But as you said, we are still at the infancy, I would say, of dissecting all of these diseases, because this is not a single disease. And obviously we didn't focus on CMML because we can't do everything in 45 minutes, but definitely will have other opportunities. And by the way, Dr. Zedan was the co-chair of the controversies in MDS that was held 2 weeks ago, 2 full days, which are available online. And then you can go and dig deeper into the field of MDS with Dr. Zedan and his guests. They have done really wonderful job as part of the IACH activities. I do apologize. We had more than 80 questions today. So I only managed to take, you know, as you noticed, maybe half a dozen of them. I tried to group some of them. But I'm sure you can reach out to the panelists, to the speakers, and they will be more than happy, I think, to answer your question. So thank you again for being loyal to the IACH activities. And as usual, I always have the same conclusion, guys. Wherever you are, please stay safe and keep well, and see you soon.
Thank you.